Something happens with it.
Yes, I think our moderator's camera has frozen. I wonder if I should just take over for a moment so we can move forward. So while our moderator joins us, it's an incredible pleasure to be able to be part again of the Women Political Leaders in the Reykjavik Forum. I've been able to join for a number of years, and so has, I know, Mark KGA Darmstadt, and we're thrilled to be able to be with you again and continue to share this work. Wonderful. Vicky, you're back. I was trying to take over in the meantime.
Having technical internet difficulties. I think it's going to be a storm here, but we will take that over from the top. Welcome to this Leaders Talk at the Reykjavik Global Forum. My name is Vicky. I'm a Sierra Leonean writer, TV host, and content producer based in Accra, Ghana. The COVID-19 pandemic has caused unprecedented health, economic, and social challenges across all dimensions. Women face disproportionate risks, which will further worsen entrenched inequalities. For example, women do 3 times as much care work at home compared to men. About 75% of the health and welfare graduates, including medicine, pharmacy, and nursing in EU member states are women. Women caregivers are 6 times as likely to suffer from depression or anxiety. And worse yet, each day, an average of 137 women are killed by a member of their own family. The paths to building forward stronger are clear. Data shows that healthy women yield healthier societies, as demonstrated by Mark KGAA's Healthy Women, Healthy Economies, Embracing Carers study. This Leaders Talk will feature new data on the value of women's contributions to health from Dr. Felicia Null, University of Miami, and to allow for discussion and insight from women political leaders on innovative women's health policies and solutions to increase women's involvement in the economy. Joining us today are women leaders like Kim Pate, Senator from the Senate of Canada, Rosalia Artiega Serrano, Executive President of the Fidel Foundation, former President of the Republic of Ecuador, 1997, and member of the WPL board. We're also being joined by Shandana Gulzar Khan, Chairperson and member of the National Assembly, Commonwealth Women Parliamentarians, Pakistan. And last but definitely not least, Lynn Taylor, Head of Healthcare, Global Government and Public Affairs, Mark KGAA Darmstadt, Germany. I would like to introduce Dr. Felicia Null, Director of the University of Miami Institute for Advanced Study of the Americas and Professor, Department of Public Health Sciences, Leonard M. Miller School of Medicine. She will share the key findings and direct implications related to Mark KGAA's Healthy Women, Healthy Economies, and Embracing Carers initiatives. The study focused on developing a gender equal health workforce and equity in the value and provision of caregiving. Dr. Felicia Null.
Thank you so much, Vicky. And let me again thank WPL and say this is a multi-year partnership and friendship that has been just incredible for our work on Healthy Women and Healthy Economy, for women's contributions, for our Lancet Commission on gender-based violence and violence against children. And so we are so thrilled to be able to have this space. And I do want to start with a very brief shout out to the person who really made a lot of this possible, which is Dr. Belen Garijo, who from years past helped set this space up for us, make sure there was this partnership, and continues from now and even larger role than when she had when we were first at WPL, and I'm sure Lynn will speak to that, to be able to ensure that this work on healthy women, healthy economies, healthy workforces, healthy economies is right front and center. So we take as our starting point the Lancet Commission on Women and Health. It was led by Anna Langer and Afaf Malaise. In 2015, we shared estimates through that commission that had gone truly around the world. We estimated then 5% of global GDP, about $3.1 trillion, was the value of women's paid and unpaid contributions to health. But we looked only at health-related work. We looked only at what were actually earnings in the marketplace. We didn't touch on the discrimination, for example, that undervalues and devalues women and their time. We are giving an update on our new estimates today that will soon be submitted to the Lancet. I'll give you approximate figures. We are talking now of 7 to 8% of GDP for women when we include discrimination, 2 to 3% for men, because we now have truly a gender approach to how we're estimating these numbers. That means a total of well over 10% of global domestic product. This is a huge number. It is also a gendered number. There are a couple of clear takeaways. Keep this number in mind, 70%. Women continue to produce the majority of paid and unpaid work around health in our world. They account for 70% of health-related work globally. And this number is remarkably stable across the 14 anchor countries that we were able to study, including, may I say, Iceland, where I wish I could be right now, but I know many of you are listening to us. Women also continue to carry the lion's share, or the lioness's share, better said, of unpaid health work, performing 2 to 3 times more than men in most countries around the world. When we add up all of that work, again, it's 70%. 70% of unpaid work is undertaken by individuals who identify as women. Framed a different way, and this is a number shared by Bev, really who's co-directing this work with me, that's 200 million full-time equivalent people in the workforce in our world. So we've said to you 70% women are overrepresented in the health workforce, but they're also undervalued. They continue to earn less than their male counterparts with similar levels of education and experience. They continue to be unable to reach, because of barriers, the same levels of leadership and the same sorts of occupation. And so we estimate the discrimination accounts for 10 to 15% of that global value of health. That may sound like a small number, but it's 1.25% of global GDP, which is enormous. It is striking to see the impact of inequitable shares of unpaid work and how this is evident in particular countries around the world. We have an esteemed panelist representing Pakistan, and so I will not go in depth or attempt to interpret these numbers, but we were truly struck by what we saw in these data. And actually it holds for India as well as for Pakistan and for much of the MENA region, that the value of men's paid work far exceeds that of women in these countries. It's the opposite trend of what we see elsewhere. That's mostly due to low female paid labor force participation in the health sector. When you include unpaid work, it flips. Women's contributions for health then account for the 70% that I had mentioned earlier. And so that kind of a situation is what we're seeing in several parts of the world. It's an example of how we're going to go into depth differentiating between these 14 anchor countries that we've been able to study. So women have been the sometimes seen, but mostly unseen motors of economies. This is also true of the health sector, which in turn is a motor for people and their well-being, but also for economic development. Care work continues to be seen as women's work, and that means that we are collectively fueling a vicious gendered cycle, even in a sector that we think has to be so sensitive to the health and well-being of each member of society, including women. 10 to 11% of global GDP is an enormous number, but it is only a fraction of the real contributions, because this does not include any of the domestic or community-based tasks that account for the health promotion and the disease prevention that is the public health face of care work and is so key. We haven't talked about that. I haven't given that in those numbers, but it's a key missing piece that we are beginning to study. And with that, I wanted to turn it over for a few minutes to Dr. Beverly Esu, who's leading that component of the study.
So thank you very much for that, Felicia. I think it is true to say that one of the missing pieces, and a key missing piece that that's been missed in the measurement in traditional and conventional approaches to measuring unpaid work is the significant role of domestic labor. This is work that's done in the private spheres of individuals' home, which continues to be gendered and continues to be hidden. This is the work that's known as socially reproductive labor that's essential for the functioning of homes and families. It was recently described in the Washington Post as the labor that enables people to perform their jobs and maintain their health. It's the dinner that keeps us going, the supply and sale of groceries, to cook such meals, to clean clothes that we put on every morning, sanitize kitchens we clean in, the empty trash cans, clean sheets, stock shelves, change bedpans, hot meals, bathe skin, firewood collected to cook meals. It can be characterized as hidden labor that provides the preconditions for health. The Lancet Commission in 2015 took a first crack at trying to estimate this for one country. We've expanded on that in this work that we're doing now, and our preliminary estimates show that across a number of countries of varying income levels, accounting for this unpaid health promoting and health supporting work by conservative estimates increases the value of health work substantially by, at a conservative, at the lower end, 2 to 3 fold increase in the value of health work. When we look at the upper range for some countries, it increases it by as much as 10 to 12 times the original estimate. So for some countries, that puts the value of health work with this comprehensive definition greater than that of GDP. And I'll just end by saying that COVID has really shone a light on the importance of this work. And we're hoping to use these estimates to help to ensure that they're part of the discussions around what the policy options are to provide greater support, as well as start to shift that gender imbalance in the provision of domestic and reproductive labor. So with that, I'll hand back over to you, Vicki. I believe you're on mute, Vicki.
Thank you. No, I was just saying, thank you so much for that, Beverly. So let's get into this conversation. Women account for 70% of the health workers in the health sector, yet leadership and decision-making positions are predominantly occupied by men. How do we change this dynamic? And I'm going to go to Kim Pate.
Sorry about that. I was having trouble unmuting. I'm very pleased to join you from Reykjavik. I have the privilege and responsibility of being here in person. I usually hail from the shores of the Kitchissippi in the unceded, unsurrendered territory of the Algonquin Anishinaabe, otherwise known as the capital of Canada in Ottawa. And I think we have a long way to go. In fact, I just left a session in the Global Forum where we were talking about the great reveal of the people's perceptions of women's leadership. And shockingly, everywhere, including here in Iceland, where the greatest, equality, if you can, of women's leadership is experienced, it is the only country that they found in the world, in the G20, where young people have a more progressive attitude about women's leadership than their than their parents. I was shocked to hear that. So I think what we have in store for us is more than just the challenging evidence that that Felicia and Beverly have just outlined for us. We also have to look at, coming out of this pandemic, how not seriously too many are taking the experiences of women. And in Canada, we know, for instance, Canada dines out often internationally on having a very good reputation around human rights protections. But we know that 70% of the or that many of the healthcare workers in Canada were women, immigrant women, that many of them lost jobs. Many of them were working full-time at minimum wage jobs, some of them 2 and 3 jobs before the pandemic hit. Many of them had to go down to one minimum wage paid job. Many of them were homeless as a result of that, made homeless during the pandemic. And we have shelter in our homeless shelters. We have women working full time in home care. That doesn't even start to count the women that you have been starting to document, which is all of the unpaid work that is being contributed by women. And the fact that we see a lack of value, not just a lack of valuing of that, but an erasure almost of that reality. And so I think we have to focus on the sorts of things that will actually create a more substantively equal situation for women, particularly racialized women, particularly women who currently work in many of these sectors and are not valued as skilled workers, despite the fact that we rely on them every day. And during this pandemic, one of the things that we looked at as a part of our duties in the Senate was the role. We know that in long-term care, they were most severely hit in terms of the deaths of elderly people. It was also not coincidental, in my view, that we're very much relying on women, particularly racialized women, immigrant women, working in those sectors who had to stop working in some of the homes so that they could work in one home only, and as part of the COVID restrictions. And we've seen that what happened when Canada stopped developing or enforcing national guidelines around the provision of healthcare, social services, economic inequality, and the need to actually go there. There was some great work done on developing the emergency benefit, but that didn't help many of these women, and certainly any women who weren't being paid before the pandemic. Obviously that didn't help. It didn't help the women who were cleaning 10, 15 houses a week, who then had to only clean one house or no houses. It didn't help the workers. And we also found that during that time, the business plans of many of the homes for people with disabilities, the homes for those who were elderly, the homes for people who were palliative, that in fact their business plans relied on the unpaid labor of family members. Guess who most of those are? The women in those families. So that the business plans of most of these homes, long-term care facilities, actually relied on labor that was then not permitted to enter the homes because of the COVID health restrictions. So we have the escalating, if you will, realities of the inequalities and the exacerbation of those equalities based on the health concerns, based on immigration status, based on class status, and the need for us to develop mechanisms to move forward. Because what we know now is that yes, we need childcare and elder care and care for those with disabilities. We also need to address the economic deficits in terms of the unpaid work, the undervalued work, and the need to ensure that we have those kinds of supports in place. So I'd like to talk a bit more about some of the options we're looking at. One of the areas that has been a huge issue for many of us is the whole idea of a guaranteed livable income, replacing the notion of poverty being something that is chosen by people, and providing the options for people to, one, stay home if they need to because they're ill, or because they feel unsafe in their work positions, or because they're trying to take care of family members, whether it's the children, elderly, or those with disabilities, or they're trying to get skills so that they can actually be in better paying jobs and with better supports going forward. So those are all some of the pieces that we're looking at, but certainly it goes without saying that the pandemic has laid bare the inequalities for those who weren't aware of them before I was going to say this country, but in Canada.
I'm sorry, Kim,
and around the world.
I'm sorry, Kim, sorry to interrupt you.
No.
I'm just going to, I'd really love for Shandana to share her thoughts on this.
Shandan, I think you're on mute still.
Right.
Is that better?
Yes.
Thank you so much, Senator Pate. It was nice to hear from you. Pleasure to meet you. And some of my very lovely colleagues are currently in the Canadian Parliament. Senator Salma Taullah, Yasmin Ratansi has just left. I work with Marie Goudreau. So it's a pleasure to have worked with Canada before, and it's lovely to be here. Thank you, Dr. Knoll. Thank you, Vicky. and Beverly, and I think I already said hello to Lynn at the beginning. As regards the first question, and I think we're still on the first question as to the 70% of women in healthcare and the decisions being made by men. Now, it's interesting that in Pakistan, as Dr. Noel already mentioned, the women and men pay structure is very different, but it's interesting that it's only different in the unregulated sector. So when it comes to medical health workers or women health workers, whether we talk about doctors, nurses, technicians, till that level, the pay scales as mandated by the Constitution are identical. The problem comes when we come into the unregulated part of the economy, medical healthcare, and that's usually the caregivers at home or the informal sector. Interestingly, part of the work I do, both in National Assembly of Pakistan and at the Commonwealth, is to look at how and where women are being impacted most, in particular in the pandemic. Interestingly, in Pakistan, we had 3 separate strands. One of them was health workers per se. Secondly, women that were already health carers at home for their mothers, mother-in-laws, father-in-laws. In Pakistan, we have a sad situation which is common to most Muslims in Bangladesh and India, is that we have a lot of first cousin marriages. They're allowed through religion, but they are not yet dysregulated or deregulated or even regulated. It used to be at some point in time through blood tests. That is no longer the case. That law was taken back, scaled back in General Zia's time, who was a military dictator. And so we no longer have screening. And because of that, 6 out of 10 children in Pakistan now are vulnerable to some sort of congenital disease, which means most mothers are going to be caregivers to their children to begin with. This system of marrying in first cousins started pretty much in the colonial era when we had small land parcels, and people haven't gotten over that mindset. It's essentially to make sure your son-in-law doesn't get the land. Now, how does it link to the women in the health pandemic? We've had surprisingly women as troopers, not decision makers, but as troopers in, for example, my province where I come from, which is the Khyber, which is on the border with Afghanistan. We have a lot of female patients from Afghanistan that trickle over the border on a daily basis, either for delivery. We don't have too many healthcare workers in Afghanistan who are women or trained, given what has happened recently. Pakistan was helping train them. Bottom line being that in Pakistan, agriculture is where 70% of women are employed. And they took the largest hit during the pandemic. Surprisingly, as I said earlier, right now, the only vulnerable segment of women in the healthcare sector are, number one, the unpaid or the unregulated domestic care workers who are providing healthcare to their families. They're usually the primary care providers to begin with. And again, it's a cultural thing. We do not have old age homes or homes for mentally ill children. So it's all done at home by the women, even if they have an external job. Secondly, perhaps the one bright thing that took place in Pakistan is something called the Ehsas program. I'll discuss that in the next questions that will come up because it is relevant to them. But for the first time in Pakistan, we have a policy which puts women at minimum of 50% for all the finances that the government has doled out in the wake of the COVID-19 pandemic. And that covers about 13 different programs, which are including straight dole-out programs. And the government chose to give those dole-out programs to 100% of women population and not men. There was positive discrimination simply because we wanted to ensure that the money would be spent on health. But I'll discuss a little bit more in the next questions. Thank you.
Vicky, I'm sorry, I think you're on mute.
Thank you. Never play that game. So women and girls carry a disproportionate share of unpaid health work and caregiving globally. How do we ensure more equitable distributions of unpaid health work and caregiving? Are there signals that the innovations in your setting are working on? Can we please start with Lynn, and then if Shandana could continue on that one.
Great, thank you so much. Yeah, this is of course a really challenging question. And if we had all the answers, we wouldn't be asking it after all. But I think there are some areas where we've been not yet able to fully implement the changes we would really benefit from, that we would all benefit from. So in 2014, 2015, our company became the private sector founder of the Healthy Women, Healthy Economies Initiative, which is a public-private partnership that looks at how to support women's health and economic empowerment. And along with the US State Department, the government of the Philippines, we created a policy toolkit to look at the ways that economies can address these very issues and questions. One of the actions outlined in the toolkit is the importance of creating a stronger paid leave policies and ensuring that they're applied consistently regardless of gender. Paid family and medical leave is critical to ensuring women are able to stay in the workforce, but very often this sort of leave has its own gender imbalance, right? Where men either don't receive equal access to paid leave or implicitly penalized for using it. And so changing the culture will always be more difficult. Normalizing men taking equal leave or utilizing workplace flexibility to take on unpaid work can't be done overnight. And for some policies, they're not even available, right? But if our policies are not gender equitable to start with, this issue will only become more difficult and an uphill battle. So it's important when facing these sorts of issues of inequity that any changes we see are modeled by leadership and those in positions of influence. And we know many men are involved in caregiving, yet it's frequently spoken about very differently than it is with women. So if we want to see equal distribution of unpaid care, we have to create an environment where men are not only encouraged, but expected to take on this responsibility, particularly by other men. So for men, workplace norms and societal expectations can at times encourage them to opt out of this unpaid work. And this is not really the case for women. So creating policies that support women is the first step to alleviate the burden, but ensuring those policies are targeted at normalizing and supporting men's care work is also essential for change. So thank you, Vicki, and I look forward to hearing from my esteemed colleagues.
Vicki, I think you're unmuted again.
Shandana, please go ahead.
Thank you so much. So as early as I was saying, was talking about the SRS program. The burden on women in the healthcare sector is twofold. Number one, we don't really have single women in this country, with the exception of I. We have a highly regulated family structure in Pakistan. Because of that, almost all girls will be mothers, depending on the financial strata of society they belong to. Most girls will become mothers between the age of 15 and 21. The second bandwidth group is between 21 and 25, and the next one between 25 and 30. Now, of course, those in the age group of 25 to 30, when they become mothers, they will probably come from economically strong families, economically strong backgrounds. Strangely enough, it took a program called Sehat Kahani, the health story, an NGO established by a very dynamic young doctor from Pakistan who realized that 70% of Pakistan's female doctors were not working, which means 70% of our female medical health force was not working either because they were mothers themselves or their husbands or their family members didn't allow them to practice. So what they did was they set up an e-medical portal through which married, unmarried, widowed, divorced, all young female doctors, 7 out of 10 women in Pakistan, 7 out of 10 women doctors in Pakistan came back to work. They have connected through this portal and they are delivering results where we didn't think they were possible, in particular to the poorest areas in Pakistan. So we've had innovative health solutions more from the private sector than from the government. What the government did do was create an awareness around the problem that women were seen as invisible healthcare workers. For example, in one of the remotest parts of my province, again, KVK, incredibly cold, close to the Himalayas, we have healthcare workers that specialize in the deliverance of polio vaccine to children, even adults at times. However, there was a long campaign of hatred during the War on Terror where these workers were maligned as distributing infertility medication to our future generations. And so they faced a huge scar of being bad women instead of being lady healthcare workers. And as a result, the government at that time, 15 years ago, didn't bother providing contracts for these healthcare workers. During COVID, what amazes me about the strength of womanhood, that they came to work despite not being paid for at least 6 months at a time. And when they were paid, after 6 months, they were paid for 1 or 2 months because their contracts were not formalized. And guess what? They were fighting for their right to work. They said, we will deal with the formalization of contracts later. What we need is access to these homes, because the women, we don't just deliver polio vaccines, we're also delivering basic gynecological services where women are either giving childbirth or having miscarriages at home. And these are remotest parts of the country. So for us, it was easy to talk to my male counterparts. Interestingly, most ministers of health in Pakistan are the men, except for 2 in Karachi, in Sindh, and in Punjab. Both the health ministers are women. And we were able to talk to them that, look, this is not a women asking to be painted as heroes. They are heroes. And so what, and don't even ask for regularization. All they're asking for is the right to work. That is, make it safe for them so they don't get shot at. And now we provide the military and police protection when they go from home to home to ensure that they're able to deliver the health care. And for me, that is something incredibly heartwarming. Practically a woman shouldn't be working if she's not getting paid, but they put those considerations aside. This should not be normalized, but it was COVID. So one of the things the government has done now is to ensure that lady healthcare workers are not seen as a sideline profession of just delivering polio medication, but as a holistic healthcare providers. So you have on the one side, Pakistan's rich young women who are female doctors and don't work. And the other, you have the poorest of the poorest healthcare providers who want to work despite not getting paid. So we've had to reconcile women from 2 different classes of society, as it were, and to bring together the example of how women can make this work. Even now at the federal level, we have a male health minister. We have a male minister who's in charge of the COVID campaign. We've been very lucky in Pakistan. Yesterday, the Economist published top 10 countries that have done rather well in the pandemic in Pakistan, topped that list, surprisingly higher than New Zealand and Hong Kong even. And that's simply because we got the military, the police to work with a civilian government. Yet, because the people in that room are almost entirely men, the trickle down has not been the kind we expected. But we're going to come out with a policy now in Pakistan, which is a empowerment policy at all levels of society, something I'm working on personally, both for the Commonwealth, and this is my last comment on this question. Something I'm working on is to ensure that, like Canada, Pakistan starts having gender-sensitive budgets and gender-sensitive FTAs, free trade agreements. Because unless your finance ministry is going to be involved, and this is also an answer to the previous question, that unless the finance ministry cares, nothing is going to move. Finance is where it all starts and where it all begins. It's not just about financial inclusivity. It's about looking at the decisions that a government makes and its impact on women, not as a women's right issue, but as a national policy issue. Thank you.
Thank you, Shandana. Kim, what innovations in Canada seem to be working, or are there any signals that they are working?
Well, coming out of one of the big pushes the government has made during the pandemic and was part of the last budget, and it was part of the election platform for the Liberal Party, was to introduce a national childcare initiative. We know that there are gender neutral policies actually almost always don't necessarily privilege women, but in the area of childcare, of course, it's something that women do need. One of the challenges, and I started to venture into it, and during the last question, was that we also need to look at the income distribution issues and the fact that we still have a massive gap between wages for men and women in most sectors, that we still don't see the incentives for people to be able to, and the support for people to leave, for instance, social assistance schemes that are incredibly punishing. And instead, we further penalize, and we don't have the kinds of national standards we need. So I see tremendous movement possible in terms of the discussions we're having about the creation of new national standards around how do we actually breathe life into the gender-based analyses that are being done of budgets, of policies, and make them real. We're also looking at how do we actually take the gig economy and create more egalitarian approaches. And we're taking a look at things like guaranteed livable incomes, pharmacare, dental care, mental health care, the things that disproportionately impact those who have the least. And so those are some promising initiatives, promising ideas. We're certainly not well on the path yet, except in the area of childcare. And we need to venture there, I think, because we will see long-term benefits in terms of healthcare savings, in terms of all of the issues that Felicia, Lynn, and Beverly have been studying and have been looking at, and that Chandana and others have commented on. So we actually need to really fundamentally look at how we make those strides, and not just in ways that are performative, but are actually transformative.
Thank you, Kim. Felicia, did you want to add to that?
I just wanted to jump in briefly, and I know that Rosalie Arteaga had to leave with a travel issue, but we had spoken before. So there were a couple of points that I know she was particularly concerned about globally on education, and also specifically to Latin America. I just want to highlight that, much of this caregiving is done by very young women, i.e. girls. And it is one of the key reasons why they don't go to school in many countries. Now, we've seen around the world successful programs that do cash transfers to actually incentivize families to have both their girls and their boys, and those of any gender, we would hope in the future, attend school. So I think we need to look at this very carefully, because what we typically see is boys are out there working, often not good, but girls are behind closed doors, unseen, unsupported, unprotected, and what they're doing is not measured. And again, this education component. And the last is that I was so struck, Chandana, about the data that you shared for Pakistan, because my husband and I have been studying this for quite a while in Mexico in particular. And exactly, we see Mexicans without healthcare and Mexican doctors without work, but the vast majority of those doctors are women. So it's the idea that medicine is actually an incredible tracer sector for us of what's happening, because the majority now, just over 50% in most countries, of those who study medicine are women. But in those who practice medicine full time in particular, in some ways, are nowhere near that number. And so again, an education message is that, at least particularly in health, the way that education practice is structured is very anti-family for both women and for men when they try to practice. But of course, this plays out much more for women who have studied medicine, who try to do their residencies, and then cannot combine that with other very important aspects of their lives.
Thank you, Felicia. Because your last comments were specifically about women in healthcare, I think this is a good time to push this question. Considering the evidence is a foundation of policy advocacy, what concrete steps can be taken to expand and improve the measurement of gender representation equity in the healthcare, in the health sector? And Kim, I'll start with you again.
Well, as you've already heard, we do gender-based analyses, and increasingly we're talking about gender-based plus analyses, which include analyses based on race, but also many of us are pushing for analyses based on class as well, because of the disproportionate impact of these policies. And one of the reasons so many of us are looking at things like guaranteed livable incomes, not UBI, not demogrants to wealthy people as well, but looking at actually bringing up the floor for folks, is because we see that disproportionately it is those who are racialized, those who are poor, who are impacted. I've already talked about that in Canada. And we've seen during this pandemic that the countries that have done the best, countries like here, Iceland, other Scandinavian countries, other countries around the world, are those often headed by women, and not surprisingly by young and in particular racialized women in many contexts, particularly in the global south. And so when we see that reality and we see that people are looking at not just GDP as a measure of recovery, but also the overall well-being, this pandemic surely has shown us that if everybody is not doing okay, then we can't rely on all of us being safe and healthy. And so we really need to be shoring up all of those sectors, in my humble opinion. And in Canada, we're looking at how do we do that in a way that is responsible and responsive, because we have things already like a guaranteed livable income through what's referred to as a child benefit in this country. Sorry, I keep saying this country, we're forgetting I'm not there right now. But we have a child benefit, which was created because we were shamed by the conditions of many young people, children living in poverty. So it's provided to parents who to make sure that they can provide for their children. It's not enough, but it was a good start. Similarly, when we got shamed into particularly women, elderly women being seen buying cat food in grocery stores because they were starving, and when we saw veterans facing that reality, we brought in a guaranteed income supplement for seniors. Now, the groups that we're still leaving behind are the people we see as undeserving. And I highly commend to folks a book that's just been written by one of our economists, Dr. Evelyn Forget, who's also looked at the income experiments that were, or pilots, I should say. They were experiments, but they were pilots in Ontario and Manitoba. And it's called Radical Trust. And it talks about the fact that we trust middle class to spend their monies. We trust the upper class to spend the money, but somehow we don't trust poor people, and we blame them for being in the situations they are. And so that we actually have to fundamentally rethink how we value people and look at what actually happens when we provide people who are economically deprived with resources. And every study shows just the opposite of the rhetoric we hear, often from middle and upper class and from academia even, is not that it gets expended in frivolous ways, not that people stay home and become lazy layabouts, but in fact, the only two groups that stay home more are those who are trying to get new skills training and those who are caring for others, presumably the very people we want to be able to stay home. And when we don't have sufficient benefits to provide for for paid sick leave, we see people going to work. And during this pandemic, we saw that as a huge health risk, particularly for the underpaid, minimally paid workers. And so those are some of the reasons that many of us are looking at a guaranteed livable income as something that first was introduced by some of my colleagues 50 years ago in the Senate of Canada, and now we're trying to breathe life into as a way to actually redirect resources that are currently expended in ways that are incredibly moralistic and absolutely insufficient to assist people, and that would actually save money in the long term in terms of the healthcare system as well as in the places like the criminal legal system. Because right now, the only systems that cannot refuse people are those emergency care systems and the criminal legal system.
Thank you, Kim. Speaking now specifically to this pandemic, how can we ensure that gender and gendered impacts are better accounted for as we rebuild towards economic recovery in the post-pandemic period? Shandana, could you please start us off on this section?
Absolutely. Thank you so much, Vicky. As I already explained, in Pakistan, had it not been for the pandemic, perhaps the radical measures that we took to bring women to the front and center of the financial inclusivity debate, sad to say, but it may never have happened. Our government, Prime Minister Imran Khan's government, came into power in 2018, August. And by the end of 2019, early 2020, we started seeing global lockdowns. Now, this is very cliche that in each challenge lies an opportunity, but I don't think anybody had foreseen the level of this challenge that is the COVID pandemic. Interestingly, as I said earlier, culturally speaking also, in a society where a large part of women have to ask the men in their family for the permission to earn or the permission to get an education, the bold step by the government in ensuring that all financial handouts for ensuring that while the strictest of the lockdowns were in place, there was food to be put on the table and medicines to be had. We also issued Pakistan's first universal access healthcare program. We've never had that in this country before. Guaranteed healthcare, which is funded by the government up to a certain amount each year for each family. And so we were able to roll those out over the objections of many other stakeholders. For instance, businesses would have rather seen those subsidies come to them rather than to people who they feel, as Senator Pate mentioned, why give money to the poorest? They're just going to burn it. That was the rhetoric in Pakistan as well. Surprisingly, that's not what happened. People kept that money, women in particular, whether they were working or non-working. And what's interesting is we copied the Brazilian model, and each woman that received that cash handout from the government had to take it on her own ID card. That ID card is now in Pakistan enabled in such a way, the data has been extracted, and this has been a data-driven example, a data-driven program, this SARS program, whereby if these women wish to open a bank account, they no longer need any male member's permission in their family to do so. We have the lowest percentage of banked women anywhere in the world, less than 1%. And so these women who could not operate even a mobile phone on their own are now in access if they wish to open a bank account. In addition, since 50% of all government-backed 13 programs with access to finance for women to all kinds of banks are now reserved solely for women, and the men in that family cannot even begin to apply for the same program, the government has put women at the center of the relief agenda, as we call it. When it comes to frontline healthcare women workers, these problems were discussed in a number of studies carried out by UN Women, UNODC, UNDP, World Bank, and all the data pointed to simply more and more training for women. And as a result, I'm happy to say that Pakistan has now started. We've had women nurses since 1947, but not a single women's training and nursing college. And now that has started in Pakistan during our tenure. So what I can say is that even in a conservative country, it is easy to do the right thing if the right opportunity presents itself. And I wish that we had done it on moralistic grounds rather than grounds of a challenge. But regardless of the causes, we have managed to take those first giant leaps for womankind. That's going to continue. That cannot be the good news. It can't be a rebound. However, as I mentioned to you earlier, our cultural problems on health in particular take up the economy. And recently I've done what I never thought I would. I met 11 clerics of my village, asked them for dinner at my house, which I would never have done had I not been in parliament, and asked them to announce from their mosques on a daily basis, if they can, that intermarriage between first cousins may be allowed by the law, but it's the worst thing they could do to their families. It's terrible for the health of the mother, it's terrible for the health of the child. And although there is reluctance because of the economic background, as I already explained, that thing has already happened. Now that needs to go through our economy. That needs to go through our schools and our mosques for women to be able to take their rightful place in their homes and in their jobs. Thank you so much.
Thank you. Felicia, how can we rebuild, build back better, basically, for better gender outcomes for women?
So I think it's an issue also of building forward. And I think I'll just say something quickly with reference to our region, the Latin America region, the Americas. Misogynistic leaders are not going to implement gender transformative policies. And sadly, we have seen misogynistic leaders brought into power, and I can say this now as civil society, in a number of countries in our region. And we hear them voice statements that are against even the health, well-being, and most fundamental rights to protection against violence. How could we ever expect them to do anything other than destroy some of the key policies and programs that could have been used for building forward? I'll take only the Mexican example where I happen to have residency and can speak to it, destroying a similar program to the one that Chandana mentioned in Brazil, which actually predated even the Brazilian one, which is the Mexican Prospera Progresa Oportunidades, took away an incredible platform for conditional cash transfers that could have been used in the way it had been built to do, which was to really generate gender equality, but also to raise the majority of families out of poverty. By destroying those programs, we have a different situation now. But on the more positive note, we have seen in a number of countries around the world, these what we used to call conditional cash transfers or transfer plus programs. They tend to cover huge tracts of the families that are poor. They tend to focus on the woman at the center with the evidence that she uses that money well for children and for families and for health. And we can build on the backs of programs like that a future that is much brighter. That's where you can support gender equal opportunities in education, support women being able to go to school, and many others. So I wanted to highlight where those programs are and how much they can be used. And actually, we're about to publish something soon in the Lancet about that for the 16 days of activism against gender-based violence.
Thank you. So right now, I'd like to invite Lynn to give us our closing remarks.
Great. Thank you, Vicki. First and foremost, I want to thank all of the other panelists here today for really an insightful conversation and for all of their efforts in this space. Also want to thank women political leaders for fostering this discussion today and for continuing to be a convener for some truly forward-thinking leaders. The problems facing women, health systems, and economies are apparent, and the innovations needed tangible. But if these paths forward were simple, I don't think any of us would be here having this discussion today. And I think this is precisely why it's so critical that this conversation is being had. The paid and unpaid care inequities facing women around the world need collaborative solutions. They need governments, civil society, and the private sector actors coming together to make real systemic changes that impact all aspects of women's lives. Healthy Women, Healthy Economies first published the policy toolkit in 2015. And unfortunately, the recommendations outlined within are just as relevant today as they were 6 years ago. The need is still there and it's still being unmet. Yes, progress is being made. The COVID-19 pandemic has shown a glaring light on unpaid work burden facing women, and women are speaking out. And finally, the whole world has been forced to face the issue everyone here today has been aware of for a really long time. So what do we do? I can say that at Merck, we recognize we must be part of the solution. We're continuing to innovate, both through global partnerships and advocacy, as well as with internal policies that support our own employees. We've implemented a series of flexible work options for our employees, including flexible hours, work from home, hybrid work models, job sharing, and leave when necessary, right? So no employee should feel they have to make a choice between caring for their family and loved ones or keeping their employment. We've also been walking the talk on our commitment to healthy women, healthy economies by creating and monitoring benchmarks to improve gender parity at our company, and with a goal to reach full gender parity in senior leadership positions by 2023. So through the work initiated by our internal Women in Leadership Employee Resource Group, we've implemented policies against MANLs, as we call them, all male interview slates, and are working to ensure our job postings don't contain unconscious bias that would discourage women from applying. We've also implemented ways to break down gendered barriers to retention and promotion, including executive sponsorship for high potential women, parity and succession planning, and unconscious bias training across the entire company. So these sorts of steps are something we believe every company can and should take internally to do their part in breaking down some of the barriers keeping women out of the workplace. So once again, I'd like to thank everyone for joining us here today and for being part of the solution. Progress is being made. There's still a long way to go, but with these continued efforts together, we will one day achieve equitable health systems and societies that will enable women to thrive. So thank you.
Thank you, Lynn. And on behalf of WPL and everyone who is doing this excellent work globally and those who support it, thank you so much. Thank you for joining us, and enjoy the rest of your time in the very hot climate over there at Reykjavik. Good night.
Thanks to everyone.
Thank you, everyone. It's a pleasure. Bye-bye.
Thank you, everyone. Take good care.